Hey, this is Gas Gangrene. I'm here with my cousin Dishwater. How you doing, Dishwater?
Dishwater revival in the house.
Oh, Dishwater. Hey, remember when we had that band that we called Crescendo Pain?
Oh, that was the best band, man. It was better than our second band.
Oh, but hang on one second. We had this manager who was a surgeon. That guy, we had this song. Remember that song that we had? What was it? What was it called? It was called...
You're a cutter?
No.
I don't like you?
No.
Why don't you ever answer my calls?
No, it was called
Why
Gas in
are
the
you
Tissue.
so grumpy all the time?
Gas in the Tissue. It was called Gas in the Tissue. And he said, you know what? I'm cutting that out, and I'm cutting out you, Gas Gangrene, and I'm cutting out you, Dishwater. I'm cutting you both out. You're done.
Yeah, well, you know what I say about that guy.
What do you say about that guy?
I'm not going to say it. I can't say it on camera.
Okay. All right. Off to the person who's going to teach you things, not this ridiculousness. We're done here.
Well, thank you, Gas Gangrene. It is a pleasure. And we're going to move on
what
to...
about Dishwater revival?
Dishwater
I'm dead to you?
You might be cut out. We'll see. We're talking about neck fash, right? Necrotizing soft tissue infections. And I don't know about you boys, but I'm assuming based on your band, you like this diagnosis. I know I do. It's a great clinical diagnosis. That's why I love it.
Crescendo pain.
Crescendo pain. All right. So did you know there's two types of neck fash? There's type 1. That's typically polymicrobial with both aerobic and anaerobic organisms. This is the one we see in our elderly patients, diabetics, those patients with decubiti, some of the sick older patient population, basically. Type 2 is that monomicrobial organism. So commonly group A strep is the culprit, MRSA, sometimes E. coli and some Bacteroides. This is a scary one because this can happen in otherwise completely healthy people at really any age. And it can happen from even the most minor skin breach, like an insect bite or a tiny little abrasion. I've seen a guy after, getting a cut on in between his toes, finally having neck fash of the leg. So this can be troublesome. It's also common in patients after childbirth. Sounds scary. IV drug users are susceptible, and if they're post-op patients as well. All right, so when we talk about the streptococcal necrotizing infections, this is the type 2 we talked about, more than 50% of patients have no identifiable portal of entry. So if you're looking for that, you're not always going to find it, only half the time. And if you do see something, it'll be minor, like the minor abrasion like we talked about. Now, here's the key, boys, as you've already discussed and I think named a song about crescendo pain.
That's our band. Yeah.
That is key. Cutaneous lesions may or may not be there. We're talking about that hemorrhagic bullae that we talk about. So if you have that, great, but you may not always have it. And just know that in general, this diagnosis has a very high mortality rate if it's delayed or missed. 70% of these patients can and will die.
That was like our fan base. 70%.
Oh, Dishwater, you still got it, Dishwater. You still got it.
All right. Clinically, how do these present? Well, you will have some soft tissue edema, pretty nonspecific. It may be erythematous and warm. It may be tender. If you get lucky, you may see some of that hemorrhagic bullae or necrosis even. But the really important key here is that pain out of proportion to the exam. That crescendo pain is very classic. If you see that needs to raise your suspicion for neck fash. And that's really one of the main differentiators from, say, other types of cellulitis. Particularly, like we talked about, if these patients are septic and hypotensive, they have that hemorrhagic bullae, they have that history of recent surgery, and they're otherwise healthy, then you need to be thinking neck fash as well. I've said this once, I'm going to say it again. This is a time-sensitive diagnosis. What I love about this diagnosis, however, is that it is clinical. So we're going to talk about some workup and treatment, but really know that the clock is ticking. You need to get your surgeon on board as soon as possible, as soon as you suspect that this is neck fash. What type of imaging do we need to get? Well, plain film is fine. You can look for gas in the tissues. If you have time and the patient is not too sick, you can get a CT, but also just your physical exam. If you feel crepitus, that's a bad sign. If you think you have gas in that tissue, you need to get on the horn with your surgeon right away. Now, what labs are helpful? Again, these are non-definitive, non-specific and sensitive, but these patients will typically have an elevated CRP. They're going to have some leukocytosis. Their creatinine may be bumped, particularly if a patient has group A strep infection. And commonly, you'll see these patients being pretty hyponatremic. Now, again, do you have to have these things? You don't. But if you have them, it certainly will add to your clinical suspicion. If you're sending off a CK and AST and ALT, those will be elevated as well. Laboratory risk indicator for necrotizing fasciitis, the LRI neck score. And we're not going to go through this. This basically evaluates a bunch of data points. Basically, if you have a high score, it increases your suspicion for neck fash.
Yeah, but memorize it because it's not going to be on the quiz.
Yeah, that's right. Memorize it. You can never look it up. Ever. Ever.
How do we manage neck fash? Boys, I'm going to give you one guess.
You cut it out. Just cut it out.
You cut it out. This is a surgical treatment. So the earlier surgery they have, the better the outcome they're going to have. So in surgery, they're going to be able to determine the extent of that infection, how far deep or far it goes. They're going to assess the need for debridement and or amputation. And they'll, of course, be getting tissue samples for culture and staining as well. From our side, what are we going to do? We're going to resuscitate these patients. They are sick. So we're going to start them on broad spectrum antibiotics, which we're going to mention in a minute. Obviously, fluids, plus or minus albumin, and transfuse them as needed. You know, hyperbaric oxygen is talked about. Honestly, I think it's too time delayed. The treatment, again, is surgery, surgery, surgery. And IVIG is also not recommended. All right, this is a big list. You don't need to memorize this. Just know that for neck fash, you want to go really broad spectrum. Typically, we'll do vancomycin plus piperacillin tazobactam plus clindamycin. Whatever you're going to do, it's typically a triple cocktail, making sure that you're covering all those organisms that this could potentially be. So in summary, boys, all patients with rapid escalation of pain, that crescendo pain in an extremity, should be raising a red flag for possible necrotizing fasciitis. If you have gas in the tissue, you're going to want an emergent surgical consultation. And remember, earlier surgery is always better. And so gas, gangrene, and dishwater, I send it back to you, boys.
Dishwater revival, man. Get it right.
Hey, Dishwater, I got a suggestion for you, Dishwater.
Let's sing like a surgeon.
Let's
Like a
get the band back
surgeon.
together.
Cut for the very first time. Like a
Like
surgeon.
a surgeon.